think we're going to start today for the sake of time. Um, Similarly to last week, I'm going to start with 3 case presentations. We will discuss some clinical and research issues in regard with our topic today, which is microcytosis and thalassemia, and then we'll readdress these cases presentation. So the first one is about a middle-aged female referred for evaluation of anemia, complaint of shortness of breath with moderate to excessive exercise and fatigue, but able to do her activity of daily living, including food, working, postmenopausal within the last year, but with a lifelong history of heavy menstrual period and irregular, no illness and medication, negative recent colonoscopy and endoscopy, vital signs within normal limits, and labs, as you see here, significant for anemia with a hemoglobin of 9, hematocrit 28, low MCV, and high borderline LDW, and with and low ferritin. So the question is, which is the best therapy at this point for this patient? Multivitamin with iron therapy, or IV, one of the modalities of IV iron, will give her some blood. The second case is another middle-aged female with history of angina, GERD, obesity, status post-gastric bypass 10 years before. Also, other complications such as endometriosis, gallstone, and depression. So early after her GI surgery, she had esophageal and gastro narrowing requiring frequent dilations, and which dificulted more her PO intake. And she presented with tiredness, shortness of breath, full tolerance to exercise, and full tolerance to PO iron. Labs are significant for significant anemia, low NCD, high LDW, very high, low iron levels. And again, the question is, should we treat her with oral iron multivitamins or some of the IV iron preparations? And lastly, this is a male with beta thalassemia intermedia, history of joint pains, and more recently with worsening anemia requiring blood transfusion, also with complication of hypogonadism, presenting with weakness, dyspnea, and poor appetite and kind of failure to thrive, and presenting with severe anemia, otherwise normal counts, and iron levels within ferritin is slightly increased. And the question is, what if you model this patient, what are the most likely findings that you will be seeing in his model? So I wanted to start with discussing microcytosis, which is basically defined as small red cells, and the test that we look at is basically the mean corpuscular volume that tends to be low, lower than 80. And then when we look at the red cell distribution width, what we find is that increased red cell distribution width, because there's cells that are small, but there's also, we're going to find reticulocytes that tend to be either normal or larger than normal. So a wide red cell distribution. When we look into microcytosis, there are some hereditary causes. The one on your left, out of those, the ones that are more prominent and frequent are the hemoglobinopathies associated with thalassemia. But also, we shouldn't forget other hereditary causes of defect of iron metabolism, so iron refractory anemia, the DMTA mutation, transferrin anemia, and sideroblastic anemia, which are rare and we're not going to address necessarily this time. Acquired type of reasons for microcytosis, the most frequent one, it's the worldwide problem, is iron deficiency anemia, but we also see it frequently presented in myelodysplastic syndrome, on myelodysplastic with thalassemia, and with deficiencies such as copper and zinc. usually this is the simple algorithm that we think through when looking into microcytic anemia. We start with iron indices. If it's abnormal, we tend to look more into the possibility of iron deficiency anemia or deficiency of other nutrients in association with borderline iron levels. When they're normal, we look more into the congenital one, and hemoglobin electrophoresis usually is very helpful, followed by molecular genetic analysis. Talking about, I'm going to spend hopefully the next 10 or 15 minutes talking about iron metabolism, since, as you know, iron is a very key element for many metabolic processes and functional systems. An average adult basically body has a significant amount of iron, most of them in the hemoglobin from the red cells, but also in other iron-containing proteins such as cytochrome, santiloxylase, myoglobin, etc. And as you know, there are multiple proteins in the body associated with mobilization and sequestration of iron. The one that are most prominent and that we know more about is transferrin, which binds the iron and is in charge of transporting it to different tissues. The ferritin, which is the classical iron storage, and it's a semi-quantitative indicator of iron storage. The iron regulatory proteins, especially IRP1 and 2, and the hepcidin that, as you know, Dr. Andrews here has had a career on looking into these negative regulators of iron absorption and metabolism. This graph here, in fact, comes from one of our publications in Blood a few years ago. Basically, despite first in panel A, the absorption of iron and the change from ferrins to ferrous in the surface of the enterocyte, and which basically is happening in the duodenum, first part of the intestine, and then the relationship of iron, the circulatory iron, and the liver using it, and also serving as an important place of storage of iron. But again, as I mentioned before, important site for the iron to go is to the bone marrow, where it becomes an important component of the hemoglobin, and then on the red cells. But also there is a significant role of from the enterohepatic circulation for the spleen, for the iron to different forms and to do some iron storage through the macrophage present in the spleen. So in regards with utilization of iron, again, it's mainly absorbing the duodenum, using the muscle, using the bone marrow, storage in the liver and the reticular endothelial cells, but we always have an increased activity of iron loss. Cell desquamation, both skin and the eye, menstrual period, and all the blood loss average almost as much iron as we take in per day. There are some instances where there is increased iron absorption, such as activities of high demand with hypermetabolic state, pregnancy and lactation, and also kids during the growth spurt had a high iron utilization. But the absorption, it depends of multiple components, not only the amount of iron in the diet, but how is the iron available, and also the requirement of iron needs by the body at some specific time. This then also summarized in another form the complex iron utilization from the ingestion to the different sites where the iron is either storage or lost, and also how the interesting distribution of metabolism of iron at the different components of that. So in regard with the losses besides the skin and all that, the total is considered that a male will lose around 1 milligram of iron per day, and a female, menstruating female, will lose up to 1.5 milligram per day of the absorbed iron. late pregnancy, again, has a high utilization and also lactation with, and that's why we give pregnant iron, pregnant patients prenatal vitamins with a lot of iron. So how do we diagnose iron deficiency, which tends to be, I think, overdiagnosed sometimes? The basic lab tests that we use, hemoglobin, hematocrit, and NCV, are very useful, especially the NCV. Not only help you to diagnose, but to evaluate how the patients are doing managed-wise in weeks or months. The transferrin saturation is another test that we use because it helps us to let us know the proportion of sites for iron binding that are occupied by iron atoms, and it's widely available. Again, I mentioned the RDW. There are a couple of tests that are not that available but are very good, especially for evaluation of functional iron deficiency. So patients that are absorbing well but really have problem with utilization of iron. Those are the percentage hypochromic erythrocyte and the reticulocyte hemoglobin content. Those are sent out tests that you can order in case to confirm that the patient are having good iron intake, but there's poor issues with utilization. The other test that is useful is the zinc protoporphyrin that help you to evaluate iron deficient with erythropoiesis of iron based on iron. A lot of time we just go ahead and do a therapeutic iron trial. We just say, if we suspect that patients are on deficiency, we treat them some course of iron, and that helps a lot. More definitive measurement, as I say, is ferritin. When it's low, is diagnosis of iron deficiency anemia, but we cannot forget that as an acute reactant, it can be either normal or elevated. In situation that a patient are iron deficient but has another illness such as inflammation or malignancy. And again, the gold standard is the iron in the bone marrow, which from our purposes, as long as you see some also blue staining in the marrow, that is consistent with enough iron in the bone marrow. Also, from the tissue point of view, the transferrin receptor is important to evaluate. It's a definitive test and it's correlated with the total mass of erythrocyte precursor. And it's used also to evaluate iron overload on some patients, as we're going to discuss furthermore. So again, we very rarely to go into a bone marrow test, but it's the presence of no iron in the bone marrow is a definitive diagnosis. In the periphery, the total iron binding capacity, the serum iron, and the low ferritin are consistent with that. I used to use, now I'm not sure with the clinic changing, what we call an iron absorption test. It's basically a very simple test that you can do in your clinic. What you do is you check the serum iron baseline, means when the patient comes to the clinic, and then give them a oral dose, usually liquid iron of 60 milligrams of iron, and then you measure the iron levels 1 and 2 hours. And the expectation is that you should see an increase on the serum iron of around 100 micrograms from the baseline that you did before you give the iron. And it helps us a lot. You a lot to evaluate those patients that either I'm taking my iron, but if you don't see it, or that you suspect that they may have absorption issues, celiac disease, or other non-specified reasons for them not to be absorbing iron, even though they're taking it appropriately. So that can be done, and it's simple, and it gives you a good rapid overview of if you need to use other alternatives for iron management. So as you know, this is a typical blood film of a patient with iron deficiency anemia. The key thing is that you see those small red cells as compared by the nucleus of a medium-sized lymphocyte. You see the hypochromia also related with that, and occasionally you see some other abnormal forms such as target cells and elliptocytes. There's different stages of developing iron deficiency. Usually the macrophages are the first one that become depleted with iron, and at that time you start to see a drop on the ferritin that could be the normal on the lower limit of normal, and at that time most of the patients still will have a normal hemoglobin. Then when we usually see the patient when they present with the low hemoglobin, low NCV, high RDW, with the peripheral meal that looks like the one that we just saw earlier, and when patients also are symptomatic with the fatigue, with the poor exercise tolerance, with the decreased performance, and also with pica, which is more common than what you think. And I have a patient that will ask the sister to bring them red clay dirt from to mail them from North Carolina because of very intense pica. When there's iron deficiency that is severe and non-standing, you can then see more systemic symptoms such as Plummer-Vinson syndrome, koilonychia, and glossitis and other complications from long-standing iron deficiency. So again, some patients will present with the cold intolerance, the pale skin, the tiredness, but very fast you see the effect of low iron in the main organs and epithelial cells, so the glossitis, the stomatitis, the leg cramping, and the esophageal web consistent with Plummer-Vinson syndrome. So the first patient presented with what we will say mild to moderate anemia, low reticulocyte count, borderline low ferritin and iron levels, and even though she claims shortness of breath with moderate to severe exercise, she was able to do activity of daily living. So at this point, the best appropriate is just to treat her with iron. You have evidence of iron deficiency, and the best way is to do oral therapy. The recommendation is 3 times a day on an empty stomach to improve absorption with the gastric juices and with addition of either a multivitamin or vitamin C, which is basically what it is. The goal is to normalize the hematological and iron indices. You can see as soon as a week after treatment that the patient starts with producing more reticulocytes, and the hemoglobin and hematocrit increase within the first few weeks of therapy. The recommendation is that you achieve a full storage of iron, so we can treat from as short as 2 to 3 months or 6 months, but also, of course, to look for the possible causes of iron deficiency. As you know, menstrual period in a menstruating female, GI bleeding as another cause, or acute blood loss due to trauma. We do see a lot of iron intolerance, as I mentioned before, and malabsorption, especially on those patients that either have GI issues that prevent the absorption or that they are very sensitive to effect of oral iron. And thus the compliance with oral iron is the non-compliance is quite high. Also, we have issues. For example, I saw a patient Friday, that he had some external hemorrhoid that had been present for more than 10 years. He had banding and multiple procedures, and he said he doesn't want to have any more done. But he bleeds from those hemorrhoids every other day. And when he bleeds, it's significant. It's red come out and all that. And so he has chronic incorrect bleeding, and he thinks that he takes the oral iron when he's not bleeding, and then he thinks that the oral iron causes bleeding, so he stops it when he starts bleeding, and it becomes a vicious circle. So you do find some patients with problems with uncorrected bleeding or with acute surgical blood loss where the oral iron is really not the best modality of therapy, and then we need to move to the IV preparations. There are multiple, there's other population that requires IV iron, as you know, the dialysis-dependent one, and there are multiple studies showing that on those patient population with chronic kidney disease and on dialysis, the goal is to have a ferritin of around 200. There's also multiple publications on the cancer literature about patients that will benefit for keeping a ferritin of higher than 100. Again, those patients with chronic blood loss, where they either have problem with absorption or the balance between the ingestion and the losing of iron is unable to be accomplished, IV iron is recommended. And on those patients with iron malabsorption too, we are seeing more and more patients with especially young females, but also male with history of gastric bypass, where iron therapy, IV iron therapy is recommended at least once a year or so. There are different preparations of iron. The classical one are the iron dextran and the infed. More recent ones are the ferlifid and the venofer, which are based on iron gluconate and sucrose as the carbohydrate present. And the one that was most recently approved by the FDA was the ferrinoxytol or ferraheme, which is a very polyglucose iron preparation that is given very fast and in a very high dose. They all have their pros and the contras. The issue with iron dextran still is the fact that there is significant association with anaphylaxis and with use of iron dextran. But the good thing is that really patients that respond to it respond very well, and that they need very few doses. Both the gluconate and the sucrose, in theory, do not need test dosing and are not associated with anaphylaxis. I particularly always do test dosing, even with this form. But you really need a much lower dose per therapy. You can only give a lower dose per therapy, so patients have to come back and back for iron therapy, which is sometimes very inconvenient. The phenoxytol, again, is a new preparation that is given IV over 1 minute, and basically the FDA-approved indication is for iron deficiency associated with CKD. CKD is stage 2 and higher, and basically patients respond very well, especially elderly patients with a couple of doses within a week apart, and they do very well. They're all available in our pharmacy and to the infusion center and in to the cancer center pharmacy. And again, this is another outline of the different type of iron that we have available. Okay, this is same, sorry. There is a study that was published a few years ago outlining the benefits of IV iron on patients with cancer chemotherapy patients. This was a study that was done in hundreds of patients, and you see here the changes from baseline on the dark to the maximum hemoglobin level, and the changes on this column on patients that responded, that were treated with either boluses or intermittent therapy with IV iron versus the oral iron. So again, now it is a standard therapy on patients that are iron deficiency in the midst of cancer chemotherapy and require erythropoietin to also treat them with IV iron, and they respond very well. The contraindications for iron, IV iron, as I say, are mainly associated with a severe reaction on the dextran forms, both allergic reactions. So not only this patient, we recommend that to test this patient, but also to have epinephrine and steroids available when you treat them. And this is much more seen in the iron dextran group than on the iron sucrose, but because of this group of patients that also have some delayed transfusion, IV iron reaction, as I say, I like to test these patients too. So the second case presentation was a lady that had a gastric bypass that has tried GI oral iron in the past. She has tried, but she had issues with absorption and gastric outlet obstruction and significant allergies. So in this case, what we choose for and she responded very well to is the IV iron, the iron sucrose, which is given again 1 gram over 4 to 5 doses. And usually what I do is I have the patient come in 6 months, check her counts, and usually every year to every year and a half they will require another course of IV iron therapy, and otherwise they do fine. I wanted to move to the other most frequent cause of microcytosis. In this case, these are hereditary. I showed, I think, the last week this graph in relation with the formation of the different chromosome location of the different genes responsive of the hemoglobin formation. When we talk about thalassemia, we basically talk about a quantitative reduction of the synthesis of the globin chain, and it could be either the alpha change, which is the one depicted here on green, or the beta change, as I say, is one of the that together constitute the normal hemoglobin molecule. There's 4 genes that are responsible for the formation of alpha thalassemia, and there's 2 genes responsible for beta thalassemia. So with alpha thalassemia, what we see is a deletion of or a mutation of one of the genes producing the alpha chain. So that reflects on an excess of the other change, the beta, or in case of the fetal hemoglobin, the gamma chain. So this, when there is a deletion of the alpha change, and in the fetal life, what we see is the hemoglobin bars. When it's a deletion of the alpha change in adult life, or on, farther down, then you see the hemoglobin H, which is a condition associated with an unstable hemoglobin, severe hemolysis, and high oxygen affinity. Most of these, again, deletions of the alpha chain happen because of genes in the chromosome 16, but there is a very high frequency of carrier state, especially in the Asian and the African continents. Again, because there are 4 genes that constitute the alpha globin, we can see deletion that goes from 1 to 4 of them. The 1 alpha deletion is basically symptomatic, and a few patients, if anything, show mildly decreased mean corpuscular volume to the point that what we see is a normal 80 and higher, and you see patients with 75, 72. When they have 2 genes deletion, then you can see then the patient may present with a worsened lower MCV and mean corpuscular hemoglobin. It's symptomatic, but if the deletion happen on a cis location, so they're missing both of the genes in from one parent, this is important for genetic counseling, because this person, depending on who they marry or who they have children to, may have a child that may have either 3 or 4 genes deletion, which is associated with with some significant clinical disease, such as chronic hemolytic anemia, unstable hemoglobin, jaundice, hepatosplenomegaly, leg ulcers, etc. And they can either see these, again, these individuals, which basically, this is associated with intrauterine death or stillborn, because there's really not unopposed gamma chain production. Management-wise, as I mentioned, the alpha thalassemia trait is not associated, most of the time it's not associated with any clinical presentation, but some of the patients may develop iron deficiency anemia. There's really not treatment besides some folic acid, either because of diet deficiency or to supplement during a hypermetabolic state. But as I mentioned before, the presence of a cis2 gene deletion should prompt some family reproductive counseling on this patient population. In relation with the beta globin beta thalassemia, what you see is the defectives of the beta globin synthesis and then an unbalanced globin production with an excess of alpha change. This excess of alpha change is associated with hemolysis, and mainly this is the key process in beta thalassemia, the ineffective erythropoiesis. And that's why the therapy for beta thalassemia is transfusion, because what you want is to suppress the bone marrow to producing any red cells, and due to the significant ineffective erythropoiesis. And there are some issues with IgG and complement binding that is associated with then the presence of splenomegaly and with bone marrow expansion. Again, the key presentation of patients with beta thalassemia is anemia, and then associated with anemia, an increased erythropoietin synthesis due to the ineffective erythropoiesis, and skeletal and system-wide abnormalities that we will address more in the next few slides. As I mentioned, basically what you see is an excess of the alpha change with the ineffective erythropoiesis manifested in the bone with osteoporosis or and poor vitamin D absorption. These patients tend to have iron overload, usually not hereditary hemochromatosis, but poor absorption or utilization of iron. They tend to have jaundice because of the increased hemolysis associated with an ineffective erythropoiesis, and then it's worsened by if the patient presents with some other congenital illness, and then tend to have infections that are worsened by some adhesive factors abnormalities. This table, sorry, is not as clear as I would like to. Basically, despite some of the thalassemia complications by age, so during childhood, what we usually see is the complication associated with infections, and also we see some of the association with chronic transfusions such as hepatitis C and B, and liver damage. When on the older patients, then you see more the consequences of not only of chronic hepatitis, but then the component of heart failure, liver failure, and the endocrinopathies, especially thyroid disease and diabetes mellitus. So heart disease, chronic infections, and endocrinopathies are what you see, especially in this patient population. Well, out of order, but basically this is to try to also show the issues with erythropoiesis and the intramedullary and extramedullary consequences of the unbalanced alpha and beta change. So what we see in the beta thalassemia, which depend on the degree of the mutation, they are what we call the silent carrier patients that we also call beta thalassemia trait. They only have usually one gene mutant, and thus they have a mild to moderate dysfunction. The typical thing that we see when we do a hemoglobin electrophoresis is that these patients have a high A2, usually more than 3.5%. They have low MCV, and they present with mild anemia. for these patients, again, there's not usually any specific therapy, except some of them can develop splenomegaly, and then splenectomy is indicated. Very rarely they develop cholelithiasis or leg ulcers, but the more important thing is really the family planning in regard with the possibility of having a child, especially in those areas that with high incidence of trait, having a child with the full mutation. Pregnant female may become more anemic, and then we do basically supportive transfusion and management of this patient population. The thalassemias intermedia and the major are basically either a homozygous state or a double heterozygous. And these patients basically are born very, very anemic and have a very high fetal hemoglobin. So the diagnosis is either done prenatally in the parents or when the child is born. For beta thalassemia major, these patients need to start treatment very early in life. So they usually started in chronic transfusion to prevent the ineffective erythropoiesis as soon as the first years of life. With thalassemia intermedia, they may not have significant anemia early on, but most of them end up having worsening anemia and worsening marrow dysfunction, and they end up having chronic transfusions and requirements in the 20s and 30s. They also then can have other complications such as osteopenia, iron overload, and consequences of ectopic marrow expansion such as osteoporosis. This is two blood films of patients with beta thalassemia. The key elements are due to the ineffective erythropoiesis, you see significant nucleated red cells both here and both here, and you see a very dysplastic marrow with target cells, with hypochromia, with poikilocytosis, with polychromatophilia. So you see big cells, small cells, target cells, and it's a marrow that is, unless you have the diagnosis of thalassemia, it can be confusing with MDS and with other dysplastic process in the marrow. This picture basically shows some of the consequences of iron, having thalassemia from the issues with the chronic transfusion and then iron overload, viral infection, and the need for then iron chelation therapy, to the osteoporosis, to the issues with splenomegaly and liver disease, hypothyroidism and the endocrinopathies, which also include hypoparathyroidism and diabetes. Patients also have problem with growth retardation, including delayed puberty and delayed secondary sexual characteristic, and also problem with bone development and then short stature. The support therapy are listed here: transfusions, iron chelation, and aggressive management of the endocrinopathies. Curative therapy they still remain within the hematopoietic stem cell transplantation. There is some experimental therapy being used, really not for curative, but for supportive therapy such as hydroxyurea, antioxidant, and erythropoietin. And hopefully in the future, we're still bargaining on hoping for gene therapy as the ultimate cure for this type of illnesses. Wanted to spend a couple of minutes on iron overload, because this is really what in this patient population is associated with significant morbidity and organ damage. This is a patient with heterozygous for thalassemia, which you see over time a slight but a steady increase on the iron levels as measured by hepatic iron. This is a test that is also readily available at Duke. It's done through when you do a liver biopsy, but it's very useful to quantify iron. I'm sorry. Then you can see this light blue line with the iron overload that happened on a patient with hereditary hemochromatosis. But in thalassemia major, given the initiation of transfusion very early, the escalation of iron overload is very, very fast and very high. And again, as soon as 25 to 75 micromole of hepatic iron is associated with risk of complication, and around 100 associated with cardiac disease and early death. So these patients very early on, before even their adolescent life, have very much complication with iron overload due to the transfusion. The three iron chelators that we use, one is the ferroxamine, one is the ferriprone, and one is Exjade. Exjade is the one most recently approved in the United States just, I think, 4 years ago, I think 2009. And these two are oral iron. This is a parental therapy. This is very well known. The problem is that it's given subcutaneous or IV. If it's given subcutaneous, it's given over 8 to 10 hours, and patient have a lot of problem with compliance and with site infections. Other complication of the desferal or the ferroxamine is auto and toxicity, retinal toxicity, and growth failure. So these patients have to be managed and followed very closely by ophthalmologists and hearing specialists. Exjade, as I say, has only been in the market for a few years. It's very good. Has kind of the same issues that from ototoxicity and retinal issues than Desferal, but it also not well tolerated and a lot of problems. It feels like a chalk, even though it's a tablet. You dissolve it in water or in apple juice, and the taste is not that good. So patients have some problem with compliance of that too, and we need to monitor renal and liver disease, and we have had to discontinue this on some patients that have had severe transaminitis due to the Exjade. The ferriprone is still not approved in the United States. They have multiple trials and is widely used in Europe, especially in Italy and in Greece. The problem is agranulocytosis, which tend to be severe and very difficult to recuperate the iron after that. So, but in Europe, again, it's used either by itself or in combination with the ferroxamine. Now here in the United States, what we have is trials of a combination therapy with Desferal and Exjade. And in fact, I have one beta thalassemia major patient that went to one of the Center of Excellence for Thalassemia in Oakland for a second opinion 2 weeks ago. And what they recommended, since his iron overload is so severe, is for me to, on top of the Exjade, bring him in once a month inpatient and give him IV Desferal. Which is associated with some cardiac, the IV with some acute cardiac disease, so it needs to be under cardiac monitorization as an inpatient. A high dose. That patient, I already give him IV Desferal when he comes for transfusion, so he gets 2 units of blood, then 500 milligrams of Desferal every 3 weeks. But they're recommending that I bring him in the hospital, give him much higher dose, like 2 grams of IV Desferal, and continue the Exjade as a combination therapy. This last patient with thalassemia intermedia presenting with worsening anemia, and now with worsening, with symptoms of weakness and dyspnea. Given the significant worsening anemia and the other findings, a model will probably show myelodysplastic changes due to chronic and ineffective erythropoiesis. So besides these typical cases of microcytosis, sometimes we find those patients that either have borderline microcytosis or that you find normal iron indices, but otherwise evidence of iron deficiency. And what we need to look is for combination of anemia, either iron deficiency and folate, or more rare but also present iron deficiency and B12 deficiency. Again, those patients where thalassemia is present as a trait, also the diagnosis of iron deficiency or the specific reason for the microcytosis is more difficult to assess. And lastly, on the pregnant patients, the interpretation of red cell indices may be difficult. And if you suspect that these patients have iron deficiency, a trial of iron for a short period of time, a couple of months, should be okay. That will not make the patient iron overload, but you will see respond by the RDW, the hemoglobin, and the MCV very fast if they really and truly iron deficiency and they don't have any problem with absorption. Just as a summary, again, iron deficiency anemia is very prevalent and has long consequences if untreated. The oral iron replacement is always the best therapy and the more affordable, but there's an increasing number of patients that are requiring and responding to IV iron, and that can be treated. That can be done without too many complications. And again, all those forms of IV iron are available here in our treatment centers, and patients should be able to receive it without any problem. Questions? Concerns? Comments?
Is there a cost difference in the IV iron?
Yeah, they're quite expensive. I think the new form, the ferrine, that's the most expensive one. So that's why I'm very sensitive to indicate it to patients that are for the FCA approval, which is CKD plus iron deficiency. I don't know the number, but it's quite high. I have seen other of my colleagues just giving because it's so easy. Patient get one push, less than a minute, but then the patient may end up with a bill. Iron is the cheapest one, and iron sucrose or venofer is in between both of them. Yeah, but with you just have to basically prove that the patient is iron deficient and that there's either absorption or compliance issues that prevent them to be treated appropriately with oral, and that's not a problem then for the insurance to cover.
And that iron dextran is still available?
Yes.
Here?
Yeah.
Is it still used, or?
Yeah, Murat Arcasoy, for example, like iron dextran very much because it's just one dose, and patients respond well. I have seen that result, so that's not my first option. But at the same time, I have a couple of patients that came to me, both of them with gastric bypass, history of treatment with iron dextran, and I'll give them the iron dextran. So I'll give it to them, so it's available. Yeah.
And with your second case, it was just iron sucrose versus the iron.
Yeah, just it's new patient. She didn't need a replacement right away. She was okay with coming for a few doses, and so if I have to choose, I choose the sucrose versus the dextran. And it's just again I have seen horrible anaphylactic reaction with the dextran, but it's as I say, I have patients that have used the dextran and they're fine, and I give them the dextran. I don't even give them a test dose. They may come every year, every 2 years, and I'll give them again, hook them back into their treatment without any testing dose.